Coming up on Why Should I Trust You? A rare conversation bringing together two groups who don't talk to each other very much, even though they talk about each other a lot. Public health and the Make America Healthy Again movement. Meaningful dialogue between these two groups just does not happen. The chasms appear too wide and too deep. Over vaccines, over the imagining of our government and its role in the health of our people, over disease itself, and over Robert F. Kennedy Jr., the nation's chief health secretary, who is a lightning rod, dividing opinions about health in our country. So what is happening instead? Our mistrust for each other is deepening. So we thought, why don't we try to bring these two groups together in conversation? Mainstream public health and the Make America Healthy Again movement. And to our surprise, when we floated the idea, the response was, count me in. So how'd it go? We'll play some of the conversation for you today. Let's get started. Hi, welcome. Guys, we have a pretty special episode lined up for you today. First, some intros. I'm Brenda Adhikari.
I'm Tom Johnson.
I'm Dr. Maggie Bartlett. Oh, messed it up already.
People need to know this is live podcasting. Tom, who are we?
You are Brenda. I'm Tom Johnson. We've got Maggie Bartlett and Dr. Mark Abdel-Malik. And Maggie's a virologist. You and I are journalists. And Mark is, as we said, a doctor.
That's right. Listen, if you're joining us for the first time, welcome. A little context. This show is about exploring a wide variety of perspectives on one big issue. Why we have such a breakdown in trust for public health, medicine, and science, and what, if anything, can be done to rebuild it. That means talking with people who've lost trust in the establishment and public health, from everyday working Americans of all political stripes to the MAHA movement, to journalists, to all kinds of folks, along with voices you might associate with what's known as the establishment, I guess, for lack of a better phrase, establishment, public health, and government. On the show, we usually hear from one or the other perspective on any given episode. But what you're about to hear today is different. This time, we asked a group of MAHA supporters and organizers from a local chapter in Ohio, along with a handful of public health veterans, if they'd be willing to sit down together and talk at length for what turns out will be the first in many conversations to come about their vision about health in this country right now. I'll just quickly tell you the story about how this conversation happened. I met a woman by the name of Brenda Newberry, who is from Ohio. I checked with her if I could talk about this, and she said I could. She's from Ohio. I met her through Braver Angels, and she worked for the Ohio for Kennedy campaign. She and I just kind of got talking about health and Make America Healthy Again and just different things. And she just became a real big fan of the show. She listened to our episodes, took notes, would call me. We'd have long conversations about the episodes. And then finally one day she was like, I'd really love for you to meet some of my friends. And some of her friends happened to be one of them, Elizabeth Frost, who is from the Make America Healthy Again movement in Ohio. We're going to talk to her in just a minute. And the same thing with public health. We've been reaching out to folks in the public health community now for almost a year, and we've built a lot of bonds. We've really chatted with a lot of people there.
Yeah, and it's so much of this these days are people talking past each other. They're kind of in their own silos. And I know that we felt sometimes where we're sort of carrying a message from one group to the other group. And, there's a lot of conceptions of the different sides, and they're not always accurate. And so I think that was also sort of the genesis of this bigger conversation.
I want to bring in two of the voices from that conversation who've been kind enough to join us today. The first is Dr. Megan Ranney, an emergency physician, researcher, and dean of the Yale School of Public Health. Hi, Megan.
Welcome, doctor.
Hi, everybody. It's a joy and a privilege to join you today.
And joining her is Elizabeth Frost, who is a grassroots organizer from the Ohio River Valley, a region often described as ground zero for the opioid epidemic. She previously served as state director for RFK Jr.'s presidential campaign. Elizabeth now works as the grassroots coordinator for the Make America Healthy Again movement in Ohio. Welcome, Elizabeth.
Hi, welcome. I'm so happy to be here.
Well, Megan, Elizabeth, we're really glad you're here. And basically, we wanted to play the first chunk of this conversation. It was a long conversation. We invited folks on Zoom. It was 5 people from public health, 5 people from the Make America Healthy Again movement in Ohio. So we're going to go back and hit play. But before we do that, we just want to briefly ask you both to go back in your minds to a few days or so before this conversation and just tell us kind of what you were feeling. What did you have apprehension? tension? What was going through your mind? Why don't we start with you, Megan?
I was both nervous and excited, but also kind of honored by the generosity and trust that both sides were extending to each other. Wasn't really sure how the conversation would go, but felt that it was worth trying as an ER doctor, as someone who did not grow up in the Northeast. It's important to me to hear all voices, and I believe that we all want ourselves and our families to be healthy. And so I was excited to get to start that conversation.
Elizabeth, what did you think?
It was definitely, I think, nerve-wracking going into it, particularly just, we're not doctors on the MAHA Grassroots side. We're not scientists, we're not virologists, but we are people who are affected by decisions that are made kind of from the top down. And there's a lot of real lived experiences in that. So, that was something that was really important to us going into the conversation.
For sure. So just a couple of things. There were about 10 to 12 people on the call. From the MAHA Ohio chapter, it's Elizabeth Frost, Daniel DeLuca, Nancy Fuller, Mark Harris, Donald Wiggins. And from public health, you've got Megan Ranney, Craig Spencer, Caitlin Jetelina, Reed Tuckson, and Paul Offit. I know it may be a little challenging to kind of follow who's saying what, but just kind of stick with us. I think it'll be pretty evident based on what people are saying. I also just need to say that a couple of weeks ago, I had a bad cold. My voice, if you recall Marlon Brando in The Godfather, imagine him with laryngitis. That's what I sounded like. We kicked it off by asking, what drives your current perception of health, how you kind of got to where you are right now. So this is part one of our conversation, and Danny DeLuca kicks it off. He's from the MAHA chapter in Ohio.
I guess I had a very interesting experience from the service industry side during the pandemic for sure, because, I own a college bar and it's on a college campus, and we had to go from, had to deal with the different regulations that were coming out, like the mask requirements, making people sit down, closing at 10. My trust in the whole medical system, I guess, has always been pretty strong. I've always been, pro-vaccine as far as from myself and all that kind of thing. I've never had a question really when it came to that. I will say when it came to COVID and the COVID vaccine, there were a few questions as far as that went that I was very curious about. I was one of the earlier people in my friend group to know about COVID and start warning people early on. When I saw like schools in China being shut down, I was like, there's going to be a problem. It's very culturally important for schools in China to stay open. And if they're shutting it down, then it's a very big concern. So I very much warned a lot of people that this virus was coming, even though they didn't want to believe me at all. Then once it was here, how to take zinc and take, different things to prepare your body for if you got the virus. So it was, and then when this vaccine came out, there were a lot of questions that I think that caused me to, as a person of science, I consider myself, I'm a big history person, but I did zoology and paleontology my whole life. So when they were, expressing how the virus might have went from a bat to a pangolin to a human, I knew that would have required a huge mutation rate, especially if it was only in a wet market area. It definitely made me question the whole nature aspect that they were pushing at the beginning. So that was definitely something that made me start questioning a lot of the stuff that was coming out, because that clearly didn't make sense at the time.
Yeah. Hey, guys. I'm Caitlin Jetelina, epidemiologist. So I study viruses and health impacts and why they happen. During the pandemic, I was part of the Texas response, actually, and at the same time, I started a newsletter. I call it Your Local Epidemiologist, because I just couldn't believe how little understandable, timely, and helpful information there was coming out at the time for Americans. And I still write that today, trying to guide people to make evidence-based decisions. I was brought into CDC about 3 years ago to be a disruptor because I was so angry about what was happening within that system. It was really, really hard to change. I'll just say that once I got in. I was dodged, I think the word is, 2 months ago. So no longer doing any of that work. But your question, Brenda, of what drives me is I'm a mom. I have a crazy 4 and 5-year-old, and they exhaust me, but they are what gives me hope and what I fight for. And so I'm in California. Elizabeth, super excited to hear you're into like nutrition because we have school lunches here that every child gets, including my kids, and that's me. And I'm so honored to be here.
Hi there. I'm Nancy Fuller. I'm from Cincinnati, Ohio. The main reason for my affiliation with MAHA is also as a mom. And I have 3 adult sons, awesome young men. And 2 of the 3 have been greatly impacted neurologically. And the question at the end of the day becomes how and why. And I'm still asking those questions. My one middle son, who's now 32, he has autism, and he's probably moderate if people want to know. He has epilepsy, high anxiety, OCD, significant food allergies, allergies to environmental things. So he's very, very vulnerable. And I would just say, I don't know if anybody on this call has lived with someone with autism, but I have now for 32 years. And I just represent one of millions of moms out there, and it's a significant, life-changing, day-to-day struggle. And so I come from that vantage point. I have my youngest son, and we chose to do a more delayed vaccine schedule for him, but he is not on the spectrum that we're aware of. But he too has had chronic, very high anxiety, very high depression, major depression at different times, OCD. And as he left college, he graduated college, did well, but couldn't keep up with the work pace. And his anxiety got the best of him. And a guy selling him just weed said, you need this pill. This is going to help you maintain things. And that pill was an opioid. And so my youngest son became addicted to opioids. And that was a whole nother chapter in our lives. But praise God, he has been sober of those hard drugs after a long litany. We could go on forever about his recovery. But he's been sober from opioids for about 5 years. And I'm truly grateful. So I've been following RFK for a long time when I wasn't getting the answers I was hoping for from mainstream medical doctors that I've versed with. And I've got some stories to share if you want to hear them about when we pulled my son off different foods, how specifically the one with autism, how things change with epilepsy and everything else. So sorry to take so much time, but that's my interest and that's why I'm here today.
Hi, everybody. It's really nice to meet you. My name is Megan Ranney. I'm originally from Buffalo, New York, born and raised there. I'm the dean of the Yale School of Public Health. I'm also a practicing emergency physician and mom of 2. I've got a 13-year-old and a 16-year-old, and I'm married to my kindergarten sweetheart, who's also from Buffalo, New York. And to those in Ohio, my in-laws live in Marysville, and my best friend lives in Columbus. So kind of appreciation for the Ohio region. So why I'm involved in this is kind of threefold. The first is as an emergency physician, and Craig will probably echo me here. I've been on the front lines for my whole career to all of the ways in which the system is broken and lets our patients down. And so I got involved with public health because I didn't want to have to take care of people for things that could be preventable. And I didn't want to have to kind of band-aid problems and then send them back out into the same system that got them sick in whatever way, mentally, physically, through injury, right, through chronic disease. It's like in the ER, we band-aid them and then we send them back out into the exact same system. And so I got involved in public health. That was kind of the first big thing, was because I wanted to change those systems that brought people into my doors and then that kept them sick. after they left. The second thing is that as a researcher and scientist myself, I got really frustrated because we often do really interesting and important work, and then I watch it just sit. So we discover things, we find associations between like some of the stuff, Elizabeth and Nancy, that you've talked about, exposures and downstream problems, or I was on the front lines when the opioid epidemic kind of presented itself in ERs. And we were saying, we could see already kind of the link between oxycodone and then kind of rising rates of opioid addiction and then the spreading of fentanyl. And so we do this research and it would sit and it wouldn't get spread. So that's like the second big thing. And that's actually why I'm now a dean, is because I'm committed to making sure that the work that we do actually gets into the hands of people that need it so that people can be empowered in their own communities to create change, to make themselves healthier. And then the third reason is because of my family. Much of my family is still in Buffalo, Ohio, Michigan, although my parents now live close to me. And I've watched, as you guys talk about the problems that you've dealt with your own families, I've watched the same thing in mine. And it's incredibly frustrating to me to not have answers to them and to have them call me because they know that I'm a doctor and a public health professional and know that they're not getting those kind of answers. They don't have access to those solutions anywhere else. Finally, I feel like I would be remiss to not talk about COVID. I was obviously very much on the front lines through COVID. And Danny, one of the things that also, like, as I talk about those systems barriers, I was part of getting schools reopened in Rhode Island and in Connecticut in September of 2020. And one of the reasons why I'm so excited to talk to you guys is because I get very frustrated that I feel like public health gets blamed for things that were not necessary. Like, actually, many people in public health were talking about the importance of reopening schools. And I feel like there's this total disconnect between many of us who work in the field and care so deeply about communities and about balancing different types of health and in the way that it gets implemented and put on families and businesses and communities. And so that's one of the things that I'm just thrilled to be kind of in this room about today.
Thanks, Megan. Should we go Donald?
Thanks, Brenda. So I come to this as an emissary of love, hope, unity, and joy. And so I'm an attorney by trade, but I'm originally from New York City. My grandparents were born and raised in the South, Alabama, and then moved to Ethalsville, Alabama, moved to Columbus, Mississippi. I've spent my summers in Mississippi, and then I spent my time prior to grad school in Illinois and then in Ohio. I bring that up to say that my experience has been varied geographically. And so I approach this from a philosophical and legal perspective, that what COVID did for me, it made me realize how much corporate capture has occurred in terms of the cultural ecology of freedom within the country. Like, it's one way in which we perceive things should be done, as opposed to the number of ways in which we can actually approach public health and the way in which people actually approach the conversation. And so I am not pro or anti-vaccine. I think that the nomenclature that we have is evolving in the country, and instead what we should be focusing on is how can we actually ensure people have access to information and understanding to be able to make the public health decisions that are best for them.
My name is Craig. I am here because, if you notice from the mess behind me, I also have a 6-year-old and a 4-year-old. Also, I have a lot of ties. I grew up in Detroit. My dad put up garage doors for the big three. And so I've seen kind of the ups and downs of what's happened over the past few decades. And they now live in Florida. But my wife's family is in Cincinnati. She was born in Louisville. And if she was here, she would correct me because I just said it wrong for the 8,000th time. And I'll be in Cincinnati next week for the Flying Pig. So I have a lot of ties. I love it. And I understand a lot of the health issues that I think you're all bringing up, because I still have family there that I talked to and messaged with a lot throughout COVID about their concerns. My father-in-law was a teacher in Cincinnati public schools all throughout. So I know a lot of the issues. I'm an ER doctor. I was working in New York City in March 2020 when COVID came in to our emergency rooms and caused what I said then and what I continue to say was the closest thing I've ever seen to the apocalypse. I say that in light of the fact that, like, for the last decade before COVID, I spent 6 months of every year working internationally, primarily in civil conflict or in disease outbreaks. In 2014, I was working in Guinea in West Africa, taking care of Ebola patients, and somehow in that process got infected myself and survived Ebola back here in the US. But that, in a sense, kind of radicalized me because it turned me into a pretty fierce advocate, particularly around pharmaceuticals. I was taking care of patients and had very little to save people's lives in Guinea. And I came back to a hospital in New York City that had more doctors on staff in one hospital than Guinea, Liberia, and Sierra Leone combined. I had access to anything I want. They were willing to fly me an investigational therapeutic from another country to give to me. And when I was taking care of patients, I wasn't able to give them really anything. And so after that, I've thought a lot about equity, particularly around vaccines. I think it's funny that a lot of people call me a pharmaceutical shill, but throughout the pandemic, I was the person in our organization at Doctors Without Borders where I work, kind of really pushing us for vaccine equity to think about how we get vaccines and treatments to other places around the world. And so I come to this call focused a lot on what's happening here in this country as an ER doctor, as someone passionate about public health, but also concerned about what's happening outside the borders of our own country and how that's going to impact us. And I know that the A is a very important part of MAHA, but what I've noticed leading measles vaccination campaigns in the Congo or doing a lot of other kind of outbreak response abroad is that if we let a lot of those issues linger and fester and don't invest in them, they will undoubtedly come here. And then I'm concerned about our ability to respond to those things here. So thank you.
My name's Mark Harris. I'm from southeastern Ohio, Athens County. I've lived here my entire life. And, what really kind of brought me to this movement, I'm a staunch independent. I really have problems with the two major parties and how they handle a lot of things. That pushed me towards independent candidates, and that was RFK in this last cycle. And, I came from this from a perspective where I had general questions about public health. My girlfriend's a type 1 diabetic. There's, things you learn in that process about how, it's not necessarily humanized. It's really highly corporatized. I mean, for example, there's like a 300% markup on insulin and certain insulin products. It's a struggle at times, even when you do everything right, to make sure that when your prescription needs renewed for insulin, that happens every year, which, until they find a cure, which that's a whole nother kettle of fish I could get into and maybe will later in the call. But, it's something that you're going to need your whole life. The fact that every year you have to go through this struggle to get re-prescribed the medicine you need every day in your life just builds a level of distrust. But that's kind of more from an experiential side. Once I got involved with the Kennedy campaign, I was able to meet a lot of people who had personal experiences similar to Nancy and other experiences that dissimilar to Nancy that made me realize that there is not just a concern here generally, but there's a politically motivated group that wants to see answers done and want to see something achieved here. I think that's really what the MAHA movement really stands out to me, is this is something that organically figured out a way to get political traction in a way that doesn't align with the two major political parties perfectly. And to your point, Craig, with the A at MAHA, I'll be honest with you. I think the MAHA terminology is a convenient political rhetoric. I don't think the majority of MAHA supporters really care if that is all domestic spending or if we take up issues outside of the country, if it's beneficial to our health. I don't think anybody begrudges the health of anybody else in the world in this movement, or at least no one I've interacted with. I think that's more of it meshes with the larger political messaging that the current administration has and the base built around that, which also I would say of all the MAGA Trump era Republican aligned groups underneath that umbrella, I'd say MAHA is probably on the outer side of this. A lot of us, especially I can speak for myself, who came from the Kennedy campaign and then into this, I'm not the biggest fan of the president's overall policies, but getting this issue to the forefront was important. And I think that's where people see the benefit to this. So I think my point being is my background's a little more on the political and political organizing side more than the medical side, but that feeds a lot of seeing what real world concerns look like and what kind of messaging resonates with people.
Thank you, Mark. And last but not least, Dr. Paul Offit. Hi, Paul.
Hi.
Is that a dog behind you?
It's possible. We do have a dog. Yep, that's a dog behind.
I just noticed some motion.
I was born and raised in Baltimore, Maryland. At 5 years of age, I was hospitalized at the Kernan's Hospital for Crippled Children in a polio ward. I hadn't had polio. I'd had a failed operation on my right foot for a congenital abnormality, but that landed me in a polio ward for about 6 weeks. So I remember polio. I remember the iron lungs. I remember the Sister Kenny hot pack treatments, which caused children to scream loudly. There was only one visiting hour a week. My father never came because he was a traveling salesman. My mother was ill with a complication with pregnancy with my brother, so she never came. And so you're there for 6 weeks and watching children scream out in pain and breathe through a mechanical ventilator. It was a Dickens-like experience. And I think, frankly, it scarred me for the rest of my life. And I think it's the scars of our childhood invariably become the passions of our adulthood. I think it's why I went into pediatrics. I think in many ways, when I see children in beds at our hospital, Children's Hospital Philadelphia, I see myself. And I think it's why I chose pediatric infectious diseases. I think it's why probably the first book that I wrote was about a failed polio vaccine called the Cutter Incident. I think it's why I asked to be the head of the polio working group when I was on the advisory committee for immunization practices, which I think had everything to do, frankly, with moving us away from the oral polio vaccine, which was unnecessarily dangerous at that time, to the inactivated vaccine. So I think that's what motivates me in all this. I see myself as someone who stands up for, advocates for, and protects children, because at some level, I see myself in all this. Thank you.
Okay, so that was part one of a three-part conversation, or at least we're presenting it in three parts. And I got to tell you, in just my humble estimation, it just keeps getting more and more fascinating, more interesting. So we just want to pause and get your thoughts, get Megan and Elizabeth's thoughts for a second. Megan, when you hear that, when you hear these personal stories, what struck you?
We were all being quite honest. We're all motivated by our families and our community's health. There were also some underlying differences in kind of how we get there, but I heard the similarity of motivation.
What about you, Elizabeth?
Yeah, so as we were listening, I was kind of writing down a couple notes of just some things that, they hit me in the moment, and they just hit me right again, all over again, as we were listening back. But, there's no secret to someone who's been following Paul Offit or been following Robert Kennedy Jr. for a long time that there's some history between the two. But there's also so many through lines between the stories, not just between Paul and RFK, but between ourselves and Paul, and ourselves in the public health community. One thing that I'd wrote down that Paul had said just then was, the scars of our childhood invariably become the motivations of our adult life. And I think that's true for every single person that we just heard from, including myself. And he also said that he sees himself as someone who stands up for, advocates for, and protects children. And I think we're all there to some degree. Megan touched on it briefly, but there's some difference in applications and maybe some of the places where we believe that we should be looking for these answers, but we all want them.
I think one thing that's struck me that I heard a few times here in this, introductory session was that, and it's a little bit uncomfortable, I think, but it, from the outside, it looks like the Make America Healthy movement really started as a call for better answers. We talked about real concern for chronic illnesses, toxic exposures, but there was a moment, and maybe even, a time where it got so deeply intertwined with RFK Jr.'s campaign. And we heard that mentioned a few times, and it really became a political agenda. And now we're taking health, and now we're really infusing this political agenda. And maybe, Elizabeth, I wonder, do you worry that by tying MAHA so closely to, for example, a presidential run, or to a candidate who's, many would say is very controversial, to say the least, that the health part of the message that drove, like what you mentioned, some from the childhood scars that, and we heard, Nancy and what she's been experiencing, that the health part of the message is getting lost because we've piggybacked on politics so hard that instead of helping people, it's becoming a political identity. And does that end up actually distracting from the kinds of solutions that the MAHA movement says it wants? Elizabeth, what do you think of that?
Yeah, I think that that's a really, really important question and something that people in the MAHA community have, I think, been reflecting on a lot. I can speak to kind of how it started and when I first heard the coin or the phrase coined "Make America Healthy Again" or MAHA. So just to take it back to when Kennedy originally announced his run for president, health was a huge part of his platform and something that I think Americans were really craving and they weren't hearing from either of the two major parties, the two major candidates. They weren't really talking about the chronic disease epidemic, skyrocketing rates of childhood diabetes, the poor quality of ingredients in American food. And so naturally there was a hunger for that. And, Kennedy just, I think, kind of happened to be the person who was there at that time that a lot of people looked to for answers on that. I think that's something that we had touched briefly on in the call as well, is it's like when these answers aren't happening, Nancy had mentioned she was looking for a lot of answers and he was the first place that she had heard it. But when the "Make America Healthy Again" phrase kind of came along was on a merch hat. So I was working for the campaign and the first thing I thought when I saw that merch hat was, oh my goodness, this is not good. We don't need this association. We don't want this. Particularly at the time, there was no partnership or alliance between Kennedy and Trump. They were both very critical of each other. And I just didn't like it at all. And a lot of people that were also working on the campaign at the time that I had been communicating with, definitely was a popular theme amongst the staff at the time about this hat is going to grow legs. It was a MAGA hat. It just said "Make America Healthy Again." And I think it was green instead of blue or green instead of red. And there's definitely a lot of nerves about that. I think we saw it coming. We were like, oh my goodness, this hat, it might sell off the shelves. It might be a good, fundraising item, but I don't know that we're going to be able to put this cat back in the bag if people start calling it, this the MAHA movement or the "Make America Healthy Again" movement. And just kind of like we expected, it grew legs, as a lot of people are kind of picking that apart and analyzing, what does this mean? How closely is this tied to MAGA, particularly with Kennedy dropping out of the race and endorsing Trump? And there's, just a lot of implications in that word. So I think that kind of ties into your question. Like, I think this is become politically fueled, and it certainly makes a lot of folks who maybe share different political values in other areas not take us as seriously on some of these really common ground issues like PFAS, microplastics, ultra processed foods. There's so many things that I think are just kind of widely accepted as truth in society, in the medical community, especially now, that we should be watching how we consume these things. But absolutely, I think the political implications have absolutely been a challenge for us.
Yeah, so I just wanted to ask Megan, on the same side of the coin of like how political health has become, especially with the MAHA movement, how has that changed your job as being a leader in public health?
It's a really interesting question. And, when I said before that I was a little nervous about going into the call, heck, nervous going into this podcast, it is partly because of the degree to which I think things, again, that we all agree on, which is that we want our families and our communities to be healthier. That's always going to be tied to politics to some extent because there's always policy implications. But particularly the last few months, it's felt like a lot of the science and the systems that have helped to create so many of the health advances in this country have been being actively torn down. And so it definitely makes my job tougher as a dean. I don't tell people to, I don't tell people to shy away from politics, but nor should science, public health, or healthcare be the domain of one party or the other, right? We should have informed debates. We should be able to engage in discussions about what the evidence shows and what conclusions we want to draw from that evidence and how we balance the science with all the other things that make a healthy society.
Maggie, this could be just semantics, but do you feel like you are public health now? Like there's been such a shift, right? The dissident voices are now in charge of the institutions. And a lot of the institution voices have been pushed out?
So
like where do you put yourself?
It's a really interesting question. When you guys were doing the introduction and talking about kind of establishment public health, I get that I'm a dean, and I'm a dean of what I think is a pretty terrific
Did it make you cringe?
I'm a dean of a pretty terrific school of public health, but maybe this is naive of me, but I don't think of myself as establishment. I don't think of, I'm constantly trying to create change, to create a better tomorrow. And so that's kind of part one. Part two is I think we are all public health. I don't actually think public health is about government officials. Yes, there are public health officials in government, just like there are lawyers in government. But you don't have to be in government to be a lawyer. You don't have to be in government or in healthcare to be doing public health. I think, again, school committees are public health. Journalists are public health. Urban planners are doing public health. So I'm part of public health, but I don't define it. And that's true regardless of who's in the administration.
Do you think MAHA is part of public health?
Oh, that's a fun question, Mark. I would like to think so. And I will say I came away from that conversation thinking, yes, they should be. And we should be working together. And I'm sure you're going to get to this in playing the quotes, but I was really struck by some places where we are just not, to Elizabeth's point, we're just not hearing each other and sharing the same information with each other. So I think we could be, and I actually think MAHA is a great example of kind of distributed grassroots organizing on behalf of a community. I worry that we're dismantling the systems that have made possible so many of the growth in life expectancy that happened during the last century, while also very, very much acknowledging Elizabeth's points about the ways that our communities have been let down in the last 40 or 50 years.
So look, with that, we still got more conversation. And when we come back, we're going to play part 2 of this really special conversation. We'll be right back. Okay, so welcome back. We are back, and we are chatting with folks from a MAHA grassroots group, as well as some public health leaders. So let's play the second part. And I'd say in this section, we really start to get into some of the different things that are worrying each group, that are worrying MAHA and that are worrying folks in public health.
Okay, so Elizabeth, do you want to maybe just kick it off?
Something that I hear often come up as I was for Bobby Kennedy's campaign. So I've interacted, with, at this point, probably 10,000, MAHA supporters, Kennedy supporters, and a very, very common place of concern is actually looking up beyond our scientists and our doctors and talking about the revolving door between public health agencies and private industry. So, I think it's kind of become this common practice that is very understandable. It's not something to be demonized to say that folks, they start in private industry, they make their way into government positions because they are knowledgeable experts on these issues, right? You have to come from somewhere. Your education and your knowledge has to come from somewhere. And then often we find that after those, positions come to an end for one reason or another, that folks are finding themselves back in industry. I want to be clear in saying that it's not my belief that most people working in that environment are corrupted by that. I think that most people in public health, particularly everyone on this call, is guided by a sense of altruism that we really do want to make a difference. We want to see kids healthier and live long, healthy lives. But we have seen in cases like what's very close to me with the opioid epidemic, with Purdue Pharmaceuticals and Chris Wright, the doctor at the FDA who ultimately approved that drug. Later, 3 years after he came to kind of an abrupt end with his tenure at the FDA, he received a very large, very glamorous compensation package from Purdue Pharmaceuticals. But I would like to just kind of ask, to the group at large, in your time working in public health, have you come across any instances or, do you believe that
it does happen sometimes where folks can be a little bit captured by the prospects of future employment or glamorous offers. So I'll just kind of open it up, but I'd love to hear the group's thoughts on that because I know that's very, very front of mind for MAHA right now.
Paul, is that, do you want to maybe take a stab?
Sure. Well, Robert F. Kennedy Jr. often makes me one of his targets. I mean, when he gives his stump speeches, he often brings me up as someone who is an example of a farmer shill. So I'll talk about me. I'm not actually a vaccine advocate. I see myself as a science advocate. And where the science supports vaccines, I support them. And where the science doesn't support vaccines, I don't support them. When I was on the advisory committee for immunization practices, I voted no on the smallpox vaccine because I think it was a program that didn't make sense to me, even though I was the only no vote. I moved us, oh, there's our dog, but I moved us away from the, from the oral polio vaccine because although we eliminated polio from this country by 1979, for 20 years, throughout the 80s, throughout the 90s, the only polio caused in this country, 8 to 10 cases a year, was caused by the polio vaccine, which I thought was unconscionable. And it was hard to get that done because people like D.A. Henderson, who was on the short list for the Nobel Prize for his work on eradicating smallpox, or the head of the American Academy of Pediatrics, didn't want that to happen. And so there was a guy named John Salomon whose son had been paralyzed by that virus. And so one of the head of the AAP said to me, it's going to cost us $4.5 million for every case of vaccine-associated paralytic polio prevented. So I thought, I'm bringing this guy onto the committee. Tell him that, because his son was paralyzed by this virus. I voted no on the bivalent vaccine because I thought that immunological data showed that it was no better than what we had.
For COVID.
Sorry, for the COVID vaccine. And I also was one of the first to sort of get out there, much to the consternation of a lot of people in public health, to say I didn't think everybody needed a booster of COVID vaccine every year. So because a lot of other countries weren't doing that, I thought target high-risk groups. So that's how I see myself. Now, I am the co-inventor of a rotavirus vaccine. It's what I spent 26 years of my life doing. I was motivated in part by seeing a child die of rotavirus when I was a second-year resident at Children's Hospital in Pittsburgh. And that work was always motivated. I mean, as anybody who knows, anybody who works in science, the reason I went into science because I really enjoyed science. And the goal of my goal was to try and understand rotaviruses. I mean, and so I got a series of grants from NIH who funded me to study rotavirus. So you never think you're making a vaccine, just so we're clear. You're just trying to understand the virus. What parts of the virus make you sick? What parts of the virus are protective? And we created strains that became a vaccine in 2006, was recommended both by CDC and the World Health Organization. That vaccine eliminated 70,000 hospitalizations in this country caused by severe dehydration from that virus. Many residents in our hospital have never seen rotavirus-induced dehydration, whereas it was 400 cases a year when I was a resident. And it saves about 165,000 lives a year in the developing world. It was a good thing, okay? The rotavirus was a good thing. And I was always funded by NIH, but in order to make a vaccine, no company is going to make a vaccine unless you protect the technology, i.e. patent it. There is no way you're going to get a company to make it. So I could have stopped there. I could have said, look, I've gotten my grants. I've been funded for 26 years. Let somebody else figure this out. But we had made the strains that we thought could be a vaccine. Merck took it up. Merck then did the hard part, it's like research, development, implementation. And so they did the development part and made a vaccine. Now, once that was a vaccine, although I was a co-patent holder, I am the intellectual property of Children's Hospital of Philadelphia. So they, for all practical purposes, own the patent. So then they had sold the patent out. And it could have ended there. Now they didn't owe me anything. My hospital didn't owe me anything, but they decided to reward me for that work. So I was compensated for that 26-year effort. And to RFK Jr., that means I'm a pharma shill, and I'm not a pharma shill. And it really bothers me when people say that because I have always just followed the science in any of the kind of recommendations that I made. And somehow he's made making a rotavirus vaccine an evil thing when it was something that has kept children out of the hospital, which was always my goal in this. I find it really offensive, and worse, because he keeps saying that, he puts me in harm's way. I mean, I have a lot of hate mail. I've had 3 legitimate death threats that have been looked at by the FBI. Only a few months ago, an FBI person came here to say I'd been doxxed again. I was on a short list to be targeted for extermination. What is my crime, for goodness sake? I'm the co-inventor of a rotavirus vaccine. Thank you. I mean, it's like this, that. I mean, that's the risk of sounding like J.D. Vance. Shouldn't that just be thank you? But no, sorry. That was political, wasn't it?
Yeah.
So
Paul, thank you for sharing that. And he's been on our show a couple of times, and we have pushed him about this. Hi, Reed. That's Reed Tuxson, guys.
Sorry to be late, and I'm eager now to continue to listen and learn.
Thank you, Reed. Donald, go ahead.
Thank you so much, Brenda. Paul, this is during COVID and up until now, I'm constantly hearing trust the science, and I just have a question. How do you define science, and where does that abut against communication? Because some science is not stagnant, it's static. So there's also what doesn't get studied is also science, but science that has not been researched. So how does communication and the need for commerce actually abut against your definition for however you're defining science?
I guess I define science as a structure that allows one to try and understand the natural world. But it evolves. I think probably if there's one thing that we could have done much better during this pandemic, it's that when you make decisions, you're making decisions based on what you know at the time. But you have to be open-minded to the fact that you learn as you go, and that's what is, to me, the beauty of science. I don't never like terms like settled science, because I think it's in some ways that's a contradiction. What I love about science is that you can take a textbook and throw it over your shoulder without a backward glance, knowing that you are open-minded to the fact that you learn new things. I mean, there were things that I was taught as a resident at Children's Hospital in Pittsburgh that were wrong, dead wrong. I mean, when you feed a baby, you should lay them on their stomach after you feed them so they don't regurgitate the food back into their lungs. Bad idea. I mean, that only increased the incidence of sudden death syndrome, which is why you had the American Academy of Pediatrics Back to Sleep program in the early 90s. But that was a decade after I'd left at my training. So that's the beauty of science. And sure, of course, there are always things that you need to look at, but science communication is a much more difficult thing. That's why people like Caitlin and Megan are so good at this, and Maggie and others, and Tom. It's in many ways, I would say, I'm curious to hear what you guys think about this. In many ways, your scientific training is the opposite of a training of scientific communication. I mean, you're trained this way, that you the biggest mistake you can make as a scientist is to ever go beyond the data in front of you. Your data allow you to say only so much, and to go beyond that is like criminal. So therefore, a good discussion section is full of caveats. I can say this, but I really can't say this, or this. And for the science communicator, you often sound like you're waffling or unsure, and I think that is hard for people. But I'm not sure that answered your question, Donald. Did it?
In part, there's the second part, which is the alternatives. Like, how can one, for example, COVID vaccines, we promote COVID vaccines, but we also have discovered there are alternatives that were able to help to treat COVID symptoms, and that was not communicated equally. So where's the line, I guess, between trusting the science and trusting the communication of what is scientific data?
Okay, so I think the best way to prevent, and arguably the only way to prevent COVID, was a COVID vaccine. It's the only way to prevent measles is a measles vaccine. I think that there were a lot of treatments that were brought up, like ivermectin, hydroxychloroquine, as quote unquote treatments for COVID. And so I think that what science has to be open-minded to that. They have to be open-minded to the fact that it might work. And so then you have to do the kinds of studies, the prospective placebo-controlled studies that enable you to answer that question, because it is an answerable question. I mean, you're not asking how many angels can dance on the head of a pin here. You're asking, which is more of a religious question. I mean, this is an answerable question. And so then the question becomes, is it answered? So hydroxychloroquine, there were a number of studies showing that it didn't make any difference, and arguably has side effects that were dangerous. So therefore, not a good idea. And then the thing was, well, you didn't use the right dose. So then they did studies with the higher dose. Again, didn't make any difference. So I think you're right that we have to be open-minded to that. But I give credit to, I guess, the scientists and public health officials who said, all right, I don't think this necessarily makes sense that it'll work, but we'll study to see whether it works because the public is interested.
But Paul, this is a really important question, and I'm glad the way you answered it. But I think to the questioner, the dilemma that we were under, especially as you use the example of COVID, is that, as Paul said, the only way to prevent it would have been to have gotten the vaccine. That does not mean, though, that there are other things once you are ill that patients should also do to mitigate the secondary consequences of becoming ill. The challenge we had, and what we want to hopefully, as we continue these conversations beyond today with people like you, is if we were to emphasize the after you get sick treatment, that meant a lot of people were not going to get immunized on the front end, thinking that it's either one or the other instead of belt and suspenders. And so we need your assistance to be able to say, yes, it is very important to know that once you are ill, there are secondary adjuvant kinds of interventions to hopefully make that illness less severe. However, that does not obviate the need to prevent the disease on the front end. Let's do both. And that has been a very difficult message for us. And I hope that, these conversations with you and others can help us as we go forward.
Elizabeth, did I answer your question? Elizabeth, I mean, do you feel like when you look at me, you don't feel horror anymore, or you still feel the same level of horror you did before?
Well, I never felt any horror, Paul. I could promise you that. I've always been of the mind that we are all working toward a common goal, but sometimes we just get caught up working against each other, versus actually making the types of progress in the dialogue. So, if I could just jump in really quickly and kind of tag on to that, what I'm hearing is there maybe a little bit of a lack of trust that given access to all the information that people might choose to vaccinate and, seek out those therapeutics in the event that, they become infected. And I think that that's the kind of trust that the, average public, particularly MAHA voters are looking for, trust us to make the smart decisions. And often, several, probably the majority of the folks that I know in the MAHA community did get vaccinated for COVID. A lot of them don't regret it and are glad that they did so and would do it again. But I think on the topic of trust, just one thing that kind of popped in my mind is that people want to be trusted, and that kind of trust streak goes both ways. But yeah, thank you so much, Paul, and everyone else for weighing in on that.
Boy, that section had just a lot of threads for us to pull on. And first, I just want to ask you, Megan, one thing that really struck me was what feels like the central tension between treating something with therapeutics and then vaccinations as a sort of prevention. It's like treatments versus vaccines is somehow how the conversation's often presented. And I wonder kind of where your head goes when you hear that.
So I think I'm going to expand it out a little bit. It's not treatments versus vaccines. So the difference between like public health and individual level medicine or healthcare is, do we think about the individual or do we think about kind of the population and the system? So that's kind of part one. So what's going to do the most good for the most people? Balancing risks and benefits. When I think about kind of vaccines are part of a much bigger suite of prevention, right? And this is, again, where I think, Elizabeth, you and I have some real alliances here. When you think about preventing disease, I will say very clearly, vaccines are amazing in terms of reducing the burden of infectious disease, the number of childhood deaths in this country and across the globe. There are a lot of other things we have to do for prevention too, because preventing an infectious disease is only one part of health. There's lots of other parts of health also. And so I think the vaccine versus treatment kind of two-sidedness, that's too simple of a dichotomy. I don't know if that answers your question, Brenda.
No, I think it does. Elizabeth, there's also just one other thing you said that I wanted to kind of, that really might come as a surprise to a lot of folks, which is like that you said the MAHA movement for the most part, like takes vaccines and is in favor of it. I think that would come as a huge surprise to a lot of folks in science and public health and even our listeners. Tell us a little bit about that.
Yes, definitely. I'd love to. So I think one common misconception about the MAHA community is that there's any consensus at all about, how people choose to approach vaccines. Obviously, it's It's no secret that the MAHA community is probably a little bit more vaccine skeptic than a lot of other communities, but I've never heard anyone make the argument that vaccines aren't effective at preventing infectious diseases. I think that's probably the one area where there is a consensus in the MAHA community, is that yes, vaccines are a good way to prevent the spread of infectious disease. That being said, I think safety is where people have some questions. A lot of people in the MAHA community feel like there are holes in what has often been referred to as the settled science around vaccines, which I know that's something that we'll probably get into in future conversations with these folks. But Megan, to your point, I think that something that we can agree on is that we definitely do not want to be so sick as a country the next time a pandemic hits. America was already riddled with chronic disease by the time that the COVID pandemic hit, and that made it that much more difficult for us to fight these things off. So I think there's kind of three sides to it. There's preparing yourself for the infectious disease. There's trying to protect yourself from getting the infectious disease, which is the vaccine. And then there's the therapeutic side. Now, something that we didn't touch on during the call originally was that it was a little bit more than just steering people away from therapeutics. Hydroxychloroquine and ivermectin were banned. And that was, I know, definitely a moment in time that threw a lot of people in the MAHA community through a loop, that their doctors no longer had the ability to make an individual health decision, right? We're talking about the difference between patient health and public health. And a lot of doctors and pharmacists, had that ability to prescribe off-label taken away from them. And so, I think that that's where public health and patient health kind of diverged during the COVID pandemic. And we weren't allowed, or we weren't able, I should say, to exercise that separation in the way that we like to think that it operates. So hopefully that answers your question.
I think here, sometimes it's like we're talking about these issues and the nuance matters. I mean, ivermectin wasn't banned. It was never banned. It remains an off-label use. It remained a drug that we used for many other things in medicine. And I think that's kind of the important framing. And I think it's hard sometimes when you hear that maybe there was a news report of a pharmacist who wasn't able to prescribe it, that means it was banned.
Yeah, but Mark, just on that point, like I agree, ivermectin wasn't banned. I think, and Elizabeth, you can tell us what you're referring to. Families wanted hospitals to give their loved one ivermectin. Hospitals said, we have a protocol. There is no evidence that ivermectin will improve this outcome. We don't want to do that. And so therefore, people were denied that in hospital settings.
To the point where courts had to intervene, and courts even
right. You have like Zoom court cases
right.
with, cases, with arguments being made about, hey, let ivermectin be used, and hospital groups saying there's no evidence that this will help. And so I think, Elizabeth, does this sound like, I know we're going back in time here, but is this what you're remembering?
Definitely. And Mark, I do appreciate you pausing to add that nuance there, because I think there is a much better way and more clear way to kind of describe what I was referring to. So just speaking from personal experience, my mother is a nurse. She works in a rehabilitation side of a nursing home. So it's definitely a very elderly, sick population in there. They were originally prescribing hydroxychloroquine off-label for COVID treatments.
Yeah.
And, ultimately, they were not able to get pharmacists to fill those prescriptions after the CDC recommendations had come down around hydroxychloroquine and ivermectin. And the answers from the doctors and the pharmacists were that they were afraid of losing their medical license. So I think that that's the nuance that maybe, we were missing in that conversation there.
Elizabeth, let me just give you a flip side of that. So my daughter has a rare disease. She's on hydroxychloroquine. She couldn't get it during the pandemic because there was a rush of people trying to take it because they thought this was like a miracle cure. So I mean, that's not a good outcome either, right? So you give freedom, but yet it has effects, right, on people who actually need it, where medicine has established this is a good thing, this is a necessary thing for this group of people, and suddenly they can't get it.
Yeah.
And I'll just throw in one other like couples therapist thing that I'm seeing from the outside of this, which is like, You've got scientists then starting to do studies, right? Clinical trials using ivermectin, and they're doing many of them. And then finally, at the end of it all, they're saying, look, we've tried from like just all ways possible, and it's just not showing that it has an effect. Then you've got folks being like, look, I know what you're saying, but drugs are prescribed off label all the time. There's no harm to this. Certainly people taking animal horse dewormer there is. And I think all the people interested in ivermectin got sort of caricaturized as being taking horse dewormer. You had that like ridiculous FDA tweet. But like as the couples therapist, it was sort of like when both of these viewpoints are sort of thrust into an emergency situation, it's like all the nuance goes away, all of it goes away. And it's like, you're either crazy for taking ivermectin or you're crazy for making me stop. Megan, you wanted to jump in.
I was just going to say that studies actually showed that taking hydroxychloroquine was associated with higher mortality. So people who took it were more likely to die from COVID-19 than people who didn't. And so I think that was, but again, this gets into kind of the question that I think we talked about later in that discussion, which is about how do we think about information and who decides for us about what it is that we can do and what we can't. But just again, for the sake of kind of the nuance there, that studies didn't just show that hydroxychloroquine didn't do anything. They were actually shown in like huge global systematic reviews to be associated with greater mortality. And I think this is where, you know, to Paul's point of being a science advocate, I'm going to say two things. One is we do studies in order to try to get closer to the truth. And if we think that people are at risk of being harmed, we have an obligation to share that and to share that kind of in ways that are understandable and to make decisions accordingly. And the other side, though, is that the human body, it's not like laws of physics, right? I've been in public health and in medicine for over 2 decades, and we keep, again, approximating the truth. And so we come close and then we do a better study and it changes a little bit in another direction. And so I think with the hydroxychloroquine example, there were some early studies that were really suggestive that it could be really helpful. And then later studies said, actually, it looks like it's causing harm, or certainly no benefit, but looks like it's causing harm. And so then how do you adjudicate which ones to follow? And I think part of the trouble during that moment was that we were all so hyped up and amped up, and we couldn't talk to each other and hear each other. And I think, right, it's just anything that anyone said got interpreted as being political rather than being a best attempt to interpret the data as it currently stood.
Or even, I love what you just said, or even demonizing folks to want to experiment with treatments that when everybody was sort of in the fog of war going a million miles an hour, I think that was another thing that, quite frankly, has led to so much mistrust, as I'm hearing from Elizabeth and folks. Mark, you had a point.
Yeah, Elizabeth, I'm curious, as you've been hearing from the public health experts in that conversation, and now you have, Maggie, Megan, me, a doctor, we're trying to like explain some nuance and put some, perspectives on this. What are you hearing? Not just in our words, but like in the tone, in our intent. Is any of it like surprising?
So
be brutally honest.
No, it's all good stuff. So I think going back to the original conversation, the original conversation between the MAHA group and the public health group, there's definitely some nerves going into it that there would be a lot of jargon, a lot of, no, I'm a doctor. And because I said so, this is it. Right. And that's definitely not been our experience. I think that the MAHA community in many ways feels like in the past we've been kind of treated as lepers, and that we're not someone to communicate with or associate with, so it's been very heartwarming, I think, to have such open dialogue and to just be able to speak so calmly about these things. I think we're able to get so much deeper into the conversation, to unveil so much more of the nuance just by the fact that we're able to calmly and maybe even casually, is that the right way to say it? To casually discuss such important things. And I think that It's
But
amazing.
how does it move the needle though? Like if you had to be specific, let's say we were faced with another COVID like pandemic and hydroxychloroquine and ivermectin were now again on the table. Like where are you on that now?
Yeah. So I mean, if you're asking me specifically, my priority has always been to be as healthy as I could possibly be before anything ever gets to me. That was my take during COVID. That's kind of still my take today. I want to be as healthy as I possibly can be before something gets to me. If we're talking about vaccinations, to me, that's still very case by case, because of course, if we're talking about the polio vaccine and the COVID vaccine, that's two different things, two different types of technology. And so I'm very much approach everything as it comes to me. But in general, I'm not afraid to admit I'm a pro-vaccine person, on a personal level. I've always been more focused on the food side of things, kind of making sure that we're as strong as we possibly can be before these things get to us. In general, I think how these conversations are shifting the dialogue in MAHA, is understanding the human element of this a lot more. And I hope that that's kind of a vice versa effect, is realizing that we're not just talking about sides or groups of people. We're talking about people with lived experience. And so I think it's incredibly impactful. Yeah.
And I'll just say, in conversations with you, Elizabeth, with Brenda, with other folks in MAHA, I think the one thing I often hear is, it's a real vision for their lives that is not necessarily rooted in like medical interventions, right? So it's a vision for food. It's a vision for how you kind of view nature. It's a vision for how you view like your ability to really affect your health. And I think sometimes, for myself, like while again, personally, I've taken vaccines and I strongly believe in so many just medical interventions that have saved lives. I'm also somebody who is kind of curious about alternative treatments, and I have a lot of like interest in how food can impact your health and a cold and things like that. And I think what is interesting, and I really want to explore this with the group, is like, I think the vaccines conversation, for many reasons, Elizabeth, right? Some of it is the way public health approaches it, and some of it is the way MAHA leaders approach it, right? It's really caused a standstill, and we have to figure out how to be able to move forward. It's an incredibly difficult conversation. We haven't fully broached it as a group. I'm really thinking through and exploring how we talk about it. And, I think the biggest thing we're trying to do in our group is to build trust with each other so that we feel safe to have this conversation. So I just wanted to put it out there that I think, I just sometimes see just like a vision for how we view health as like, it could actually be a common vision, but it's keeping us really far apart. And I'd love to see if that distance could be broached,
Can we talk a little bit about science?
Yeah. Let's talk about science.
Let's make a podcast about that.
Megan, what do you want to say about science?
Well, what I want to say is like, I think scientists try their best to be open-minded. And the process of doing science, we like push and test each other to make sure that we're coming up with new ideas and using the best methods possible and getting, again, as close to truth as we can, given the resources that we have and the data that we have. And I think there's been this misconception, and just Elizabeth, I'm curious. I'm actually not going to say I heard, like, I'm curious about what would help folks to feel like science was being done with and for them. Because to me, that's what most scientists are in this work for. And I also hear you saying that it didn't land that way.
Yeah. I think I can speak specifically in terms of the MAHA community, is that there was a lot of outrage, for having any questions, about the way that the COVID pandemic was handled. certainly, whether it was the intent or not, people on the MAHA side of it felt very demonized and very othered, and that they weren't allowed to be a part of the conversation. Certainly there was quite a bit of censorship online during COVID. And those types of things really did a lot of damage to the trust. People felt like if they couldn't be heard, then why can't I say this? Right. And we never really got that answer. Not extremely clearly anyway, and it's particularly not in the moment. And I think for people to have a better understanding of the reasons those decisions were being made would have gone a long way. But it goes back to just the intensity in that, people were so intense in either direction at that time that it was really difficult to talk to each other.
So you guys, you're doing great. I'm going to tee up the last part of the conversation. We really start to talk about some more things involving vaccines, how they're made, also about those cuts that have come through HHS, and also how information gets disseminated to communities on the ground. Let's take a listen.
Go ahead, Mark.
Yeah, I really had two things I kind of wanted to point to. When Paul was speaking, he talked about how Merck stepped in to do the kind of develop and like scaling of taking it from the experimental to the actual production side. And it is my questioning begins in that part of things. And I think a lot of people in the community do as well. It's not so much is the researcher, is the scientist doing this work for the right reasons, making a mistake or causing problems, but the people who are doing this, they're, I guess, actualizing this for profit, like Merck would as a manufacturer. That's where the questions begin. It's like, okay, well, personally, I would trust Paul and his experience, but I don't trust the guy running the line at the Merck factory printing this stuff will not, have too many hours that day because they're trying to push this out quickly. And I think COVID really pushed that through, as well as the fact that it was so expedited. And I understand the reasons for that. It was a pandemic. We wanted to get this addressed quickly, but I think that's where some of these questions begin. And I guess the main question I would have is, what do you guys know about the actualizing of the vaccines, like the manufacturing side versus the origins and creating of the product?
Yeah. So go ahead, Paul.
Okay, so when I said sort of like research, development, implementation, the research in many ways is the easy part. That was a 10-year project. The development, it was a 16-year project. So what you have to do there is you have to do so-called phase 1, 2, and 3 studies where you have to prove the proof of concept. Are the strains that you have in there the right strains? Do you have the right dose? Do you have the right dosing interval? Do you have the right buffering agent? Do you have the right stabilizing agent? You have to do real-time stability studies with the vial that you use. That is enormously expensive. And then you do bigger and bigger trials. So then you finally do the big trial, which in the case of the rotavirus vaccine was a prospective, placebo-controlled, 72,000 baby, 11-country, probably $350 million trial. But even that, so what that shows you is that the vaccine works or it doesn't, and that the vaccine doesn't have an uncommon side effect. But it doesn't prove that it doesn't have a rare side effect. You don't know that yet. And this, I was on the FDA Vaccine Advisory Committee in December of 2020 when we approved or recommended for authorization the 2 COVID vaccine, mRNA vaccines. And your heart is in your throat. You're looking at a 40,000 person trial for placebo-controlled trial for Pfizer, which means 20,000 people, adults got a vaccine. For Moderna, 15,000. You're looking at 35,000 people that got a vaccine. You're about to make a recommendation for hundreds of millions of people. You know the other shoe is going to drop. It has to drop because there's never been a medical innovation in history that has not been associated with some human price paid for knowledge. You know that. The only question is, how severe and how rare? That's it. That's the only question. And the good news is there are systems in place to pick that up. That vaccine safety data link picked up myocarditis within weeks, which was occurring at roughly 1 per 50,000, depending on the age group, but roughly 1 per 50,000. The vaccine that was authorized in February of 2021, the Johnson & Johnson vectored virus vaccine, that was found to be a cause of clotting, including severe clotting in the brain, including fatal clotting in the brain, in as much as 1 1 in 250,000, also picked up pretty quickly. So there's no hiding, I guess is what I'm saying. If a company wants to lie, if they want to misrepresent data, they're going to be found out. They are, because we give these vaccines often to healthy young children, and therefore they're held to a very high standard.
Yeah, and Mark, I just want to add to that. I think we absolutely should view any powerful industry with skepticism. As a journalist, I have done several investigations into pharmaceutical companies. So I want you to know that whenever you have massive entities that have so much power, it is absolutely the job of journalists and the job of really Congress to make sure, and people and citizens like you, to make sure that your questions are being answered. I could not agree with you more. Craig, jump in.
Thanks. I just want to go back quickly to what you first said, Elizabeth, and what has been a through line throughout. My family is complicated. My sister died about a year ago after a struggle with opioids. My parents are pretty sick, although my mom and dad are hands down the most through and through Trump supporters you could possibly imagine. And we have a wonderful set of conversations on stuff exactly like this. And the one place where they and I really agree is about things exactly like this concern about pharmaceuticals and how they're so expensive. My mom got a kidney transplant. She wasn't worried about the kidney transplant. She was worried about the medications that come after it and how she's going to be able to afford them. We're able to figure that out. Similar to Mark, what you mentioned around insulin. When insulin was created, it was basically given for free to the world as like a gift, this incredible gift to humanity. Same with the polio vaccine, et cetera. And when I talk to my parents, the one thing that they say is, sure, NIH gives all of this money and it's really, really great. But then what happens? All of these drugs, get handed over to public or private companies and they can just make billions of dollars. And so he said, I want public money going into public goods. And so I'm curious actually for all of you looking at what's happening to things like the NIH right now and how billions of dollars are being taken away for things like chronic disease work on diseases like, what Tom shared about his family and other diseases that, don't affect a lot of people, but, have a huge impact on a few, as well as things like trying to understand the fact like 99% of all recent drugs that have FDA approval have been supported at one point by the NIH. What are your thoughts on that? And how do we improve this system so we can continue to do that work, make sure that those drugs and pharmaceuticals come to light and that we can all benefit from them?
I think that it really is a breakdown in communication in how the MAHA community and Kennedy supporters have perceived the cuts at HHS versus, how those conversations are actually happening within. There's a lot of chaos that has really made it difficult for us to even accomplish the goals that we're looking to accomplish right now. There was a gentleman that I was speaking with who was the district or the director of HHS for his district, who was laid off the day after we had a great conversation and we're making plans for things to do. So I think there's truly a lot of empathy in the MAHA community on that side of things. I can't speak on behalf of, Secretary Kennedy and say where he was at on those decisions, but just based on my firsthand knowledge of him and where he's at, I think this is something that came more from the DOJ side of things versus, what Kennedy felt like was actually going to make us healthy again. So I'm optimistic that with him at the helm, he's going to try to put the right people on the right projects to get this done. But yes, I think there's a lot of common ground to be had in how these cuts have been handled for sure.
Caitlin, do you want to?
Yeah, this is, these cuts are incredibly personal to us in public health. And I'll speak for myself. I'm having a really hard time seeing how these cuts really help the MAHA movement going forward. And I think it is what you were saying, Mark, and that there's this entanglement with politics, particularly with MAGA. And I know you raised your hand. I don't want to put you on the spot, Mark, but I would love to hear your perspective on this.
Yeah, this is actually a conversation I've been having a lot over the last week, believe it or not, with people. And I really do think my inclination, and I think Elizabeth, from her experience, also felt this, that a lot of the stuff was done around Kennedy as far as these cuts. Based off of his statements beforehand, again, I don't have any particular inside knowledge on his thought process or anything like that. But he was wanting to approach this from a kind of neutral perspective, hear what people have to say, be approachable, and then he was undercut, or at least the way I understand it, was undercut by Doge coming in and going around him. And then one of the things I wanted to see was him push back on this. But as if anybody was paying attention, when Marco Rubio tried to use his position to push back on the cuts that were happening underneath him, Trump kind of put him in his place and said, more or less let Elon make these decisions. And just to go on with how, this questioning of corporate control and, billionaires and oligarchy and all of that kind of conversation, that was a crucial component of the Kennedy campaign that kind of got set aside when he joined with the, Trump administration and all of that. And, me personally, for a couple months, it was kind of like, really, my heart was in my throat the whole time. I'm like, is this worth the trade-off? Is this worth compromising these kind of ideological conversations we were just having? And I can't speak for him. He clearly says that's the side of things that he thinks is better. He thinks it's better to focus on what he can get done within the Trump administration rather than buck that. That's not the decision I would make. But also, you got to play the game the way it shakes out sometimes in politics. And for better or for worse, I think we're getting some of the conversations. For example, getting food dyes out of food, artificial food dyes, getting that done is huge. So I see where the calculation could come from. That it is beneficial to work within the Trump administration to get these things done. But I will say about the greater MAHA movement and my conversations with people, they're not super comfortable with that. Elon's not particularly looked on well in this group. As you may remember, Nicole Shanahan, his running mate, had a tumultuous relationship with Elon, to say the least. She was very, cordial in the actual campaign process, as a politician should be. But I don't think Elon has many friends in the MAHA community, and the Doge cuts were not something I think anybody in MAHA was pushing for on the grassroots level. If that kind of answers what you were asking about.
Yeah, I mean, I think it justifies how I'm seeing all of this playing out too. I'm curious, how are you guys thinking about this on a state level? Because I agree with you that I think that there's one person making all the shots on the federal level, but where there is possibility for opportunity with dismantling of our public health systems and it coming into the interaction of MAHA lies on a state level now. And so I'm curious how you guys are thinking about this for Ohio.
Hey, can I just ask, as you answer that, maybe I could bolt on a related question, given what's at the state level is also Medicaid. And I'm wondering whether you guys have any perspective. I mean, if kids are going to be healthy, they're going to have, we're going to prevent chronic disease. They're going to have access to healthcare. And are you, in addition to Caitlin's question, are you guys at the state level focused in on preserving Medicaid?
As far as Medicaid goes, I'll be frank. I personally don't think it needs to be cut. I think anything that's giving money to help kids that need this stuff is good and should be done, and it needs to be done the right way. But we're working with Republicans who are more standard Republicans here in the state than there is. There's not a grassroots MAHA person in the state house that's like one on a MAHA ticket. This is people who are already Republicans and already in the Republican administration and in state house here in Ohio that are now looking to the MAHA movement to try to respond to what they've seen after the fact. So when it comes to speaking to people like that, their framing comes from a budget mindset and trying to cut costs, the standard Republican talking points here. And, personally, I would advocate that they don't touch that and they leave that to try to help people who still need that help and don't try to cut, funding that would help keep kids healthy. That's antithetical to my beliefs. But understanding the way the political landscape is, that I don't think that's something they're going to champion outright, but would they pass a bill like that? Would that somehow clear their caucus if they get that together sometime soon, as I, am still waiting to hear back from them? I could see that happening, but that would be something I would openly object to. And I think a lot of people in the MAHA movement would also feel that way.
Brenda,
Yes, ma'am.
I just had one more other point, and I promise I'll stop
Okay,
talking.
okay.
It was to your question earlier, Donald. You said the word scientific communication, and like my ears perked up because that has been one of the places that needs a lot of help. And I noticed that during the COVID pandemic, and it's why I dedicate a lot of time to this right now. The way I view it is that there is a distinct difference between scientific communication and advocacy. And the two were very much blurred, and I still think are very blurred during the COVID pandemic. For example, around masks, that drove me insane. I think that the way at least I approach scientific communication, and I think Megan does really well too, as well as Craig, is that we say what we know, what we don't know, and how we're trying to find answers. And if that can be done in a really systematic, empathetic, calm, steady-headed way, which can be really hard during an emergency, I'll just say that, then I think that is part of the secret sauce. The other thing, and I think this is going to what you're saying, Donald, is that the information landscape has dramatically shifted. And what is really apparent right now is there is this curiosity-driven class. And I think that is incredible. People are asking more questions and more than ever. And I think that it needs to be embraced rather than kind of shunned away. I just wrote about seed oils yesterday because I was getting so many questions about seed oils, and I learned so much about it, right? But I think that one thing public health, the institute, whoever we are calling the institution of public health, really needs to embrace is that that curiosity-driven class has been unleashed, and we need to step up for that. So that's all I wanted to say.
Thank you, Caitlin. All right, Donald and then Nancy, please.
Thank you, Brenda, and thank you, Caitlin. The way I see it, to Reed's point, Caitlin's point, Mark, and Craig, is that we need to ask better questions. And the question that is coming up, or that's kind of emanating through all of this, is not how can we save NIH? What do we think about that? How to be responsible? But how can we develop a better system? And to that curiosity class, how do we bring everyone together to the table to address their concerns? I go back to my second grade teacher, Ms. Dina Cola, who said, the 5 W's: who, what, when, where, why, and how. What are we trying to preserve? Let's stop talking about the derivative. Cash is the derivative. Commerce is the derivative. Health is the actual thing. What is it about health that we are trying to preserve? We want access. We want understanding. The lack of information is a public health crisis. Corporate capture is a public health crisis. Being bent over the barrel, and please forgive the pejorative, but because you can't afford medication for health conditions that are created by environmental conditions that are created by the actual health remedies that we're creating, is actually a public health crisis. Our system is in a public health crisis. So instead, what is it that we are trying to preserve? What is it that we are trying to do? And how can we bring the curious class, the layperson citizen who wants to work, who wants to have a family, who wants to go home, who wants to live out their life all of their days, and then go to their grave, meet their maker, and say, hey, job well done. I've done what I can do. So everything is not about commerce. Everything is not about working. Everything's not, well, how can I actually preserve NIH? How can I preserve the good that NIH is doing is the question as I see it. So
I would just say I completely agree with the premise there. In fact, so much so that in Washington, D.C., I have organized the community and based organizations and faith-based organizations in the Anacostia, the poorest part of Washington, D.C., to mount grassroots campaigns to get everybody the information and to coalesce every asset, every resource, whether it's the church resources, philanthropy, whatever, to fight against chronic disease and promote prevention. So what I'm saying to you is, we do not and cannot let money be the problem, because there isn't any funding, as we know, coming out of the CDC now for community and faith-based organizations. So it's going to be communities themselves. So I would just say to you that I agree with you completely. We've got to mobilize every asset. And I'm showing on the ground in DC that it is possible to get 60 organizations to come together as one army in the poorest part of a city and have them dedicate themselves to a vision for what does a healthy community look like, and marshal every asset no matter how little or how small, into a coordinated, leveraged fight for health. So I'm with you on that, brother. And I'd love to be able to, as follow-ups to this conversation, start to share some of that kind of work that I'm learning, and you're learning whatever you're learning on your end that will help me to do better in DC.
Nancy, your hand was up. Do you want to? Yeah, please.
Yeah, I just wanted to, because I'm living a life of experience with a mom with two sons that have many challenges. And my middle son with autism is getting current help from Medicaid, and that help subsidizes care for him. And as my husband and I age, if we didn't have those Medicaid dollars, we realized as much as we've saved, and we have saved a lot of money for our vantage point, we've saved a lot of money, but without that Medicaid to support him as we age, and if we can't care for him, it would completely be a grave change in our retirement. And I would just be in full-time care of him despite my aging. And so just so you know, Reed, you were bringing up what's going on in Ohio. Do you aware of all these cuts? We are aware. And there is a grassroots parent level of people with disabilities that I'm engaged with. We've all been advocating, writing, and petitioning to our state government to say, and I was writing stories, personal stories of what this is going to do to my family. And other families were doing the same. So we're hopeful that that's going to help drive, at least in the state of Ohio, where some of those Medicaid cuts get shifted, and they need to. So I just love to give my own personal.
And I have to tell you that just very quickly, that last story is one of the most important emotional stories that there are in healthcare, because there are so many parents who are in the same boat that you are. And I thank you for sharing that narrative. That is incredibly emotional.
Megan.
I feel like, I don't know, like I guess my question is like, how can we be helpful? And then where are the sticking points? You know, because like for me, Nancy, as you tell your story, I'm thinking about a study that one of my faculty just published looking at the effect of environmental exposures during the prenatal period and early childhood on the development of neurodevelopmental disorders, and showing that like when kids are exposed to a lot of outside light at night, when they have exposures to certain forever chemicals, that they're more likely to develop neurodevelopmental disorders. And like, I want him to be able to keep doing that work. And then for us to have the tools to take that and actually put it into communities so that we can protect folks like your kids from developing problems. I want us to use our science, to use our students, to use our faculty to do exactly the things that you are talking about, and to change the darn structures that make and keep us sick. And so I'd be so curious from your perspective about how you would see that working and what's missing in the way that folks like Paul and Caitlin and Craig and Reed and I, what's missing when you hear us?
Nancy.
Megan, to your point, I don't get information. The kind of things you're talking about and the stuff you're getting done does not filter all the way down to me and to people in my circles. So when we talk about communication, there are huge gaps. And what is, I'd ultimately love to have a dialogue about what is preventing good work to be transmitted to the right people.
I wonder, Megan, which part of this conversation I could sort of, as I was observing the public health kind of faces on the call, I really just saw all of your eyes get bigger as you sort of felt heard in the conversation about the cuts, and that they weren't necessarily saying that they agreed with them. What was going through your mind?
I was thinking like, oh, thank goodness. It's terrifying. To me, to my colleagues, to friends across the country, on a personal level, but also on a community level, to watch these cuts happening. We put FDA in place so that we could make sure that kids' medications and formula actually had what was said to be in them. We developed Medicaid and Medicare because otherwise we had people who were disabled or older or low income who literally couldn't access care. We developed systems to test water to make sure that people weren't being exposed to I mean, again, having grown up in Buffalo where there was the Love Canal, like I know what happens when there is not control of what's in the water. And so I get terrified for kind of friends and colleagues and science, but I also get terrified for the future of communities. And so there was a feeling of relief that we all agree that those things are important, while also agreeing that we have to create change in how those systems are experienced, because I don't know a single person who works in public health or in healthcare who would say that the system is perfect right now. And so, again, it was a place where I felt like there was some shared agreement, but again, relief that this, what feels like destruction, is not a universally agreed upon goal.
Yeah, and I think it was Donald who said, it shouldn't be how do we save the NIH? It should be how do we save people's lives? How do we make a better system? Like that should be our goal. And I think it's just as it's very interesting to hear public health, for me to hear public health people say, yeah, there's got to be changes in the system. And then on the other side to hear MAHA say these huge cuts and the way it's being done and the prospect of slashing Medicaid, I'm not good with that. So right there, you're sort of opening, this is like different than what you see playing out in the media, which I think just obviously just you get more extremes,
Yeah. And, Elizabeth, look, there's a way of looking at this conversation if I'm listening to it being like, man, these guys really like each other. Like that was just real kumbaya. And that seemed pretty easy. Like, are they really even talking about any hard things? And I guess, I want you to kind of address that, like, as we look ahead, because guess what? We're going out on a second date, everyone. Everyone agreed to it. We're all going to have a second conversation. We'll let you know how it goes. And in fact, Elizabeth and I are talking about potentially expanding this to some other locations around the country with folks in public health. I think there's some interest. But I guess my question, Elizabeth, I want to talk about the hard things. And what I would just ask is, like, what goes through your mind and what are some of the conversations that you really want to dig into that maybe we even sort of got a taste of on that call, but when you're talking to folks in MAHA, that you're like, these are really the sticking points for us?
Yeah, I'm actually really excited by the prospect that I think some of the biggest priorities for MAHA are things where we do have common ground in food and water, as Megan referred to. You hit the nail on the head earlier. Really, the big sticking point for a lot of people is the issue of vaccines. And I think that hopefully we are able to round out and add some nuance to where MAHA really stands on those issues. And also where MAHA diverges from the broader umbrella of MAGA, right? I think there's a lot of associations there that have led to a lot of hurt, like particularly in the area. I think that the narrative has really been that MAHA, has co-signed a lot of these cuts. And I think that's something we were able to get into and to kind of reveal that that's not really where a lot of people are at right now. But yeah, I mean, I think that the issue of vaccines is the only place where we're really going to have, maybe a little bit more of disagreement on these issues.
I mean, I'm going to name like a couple more. So one thing I push public health on a lot is on the issue of corporate influence. I think that it makes a lot of folks in public health very uncomfortable to talk about it, because I know that, the scientific research community and the pharmaceutical industry they've worked together in many cases very well, but in other cases, as you mentioned, in the opioid epidemic, there were lots of problems. I think that's a space that needs to be worked through. And the other part that I just feel like I really would just love to just talk a little bit more about our views on science, and our views on studies and how we approach curiosity. And because I just see, even when RFK Jr. talks about germ theory or things like that, that there are just some foundational things that you know make the other side go, well, I can't even talk to him if he doesn't believe in germ theory. Are you actually saying that? Is there something else that you're trying to say? So these are things that I'm also thinking through. Mark, did you want to jump in?
So, I've been reporting on things that are, real cuts that are happening right now. And it just seems like there's this idea that we can try to figure out where we have common ground. And I feel like we're way past that on so many things, because yes, we can have common ground on food and water. And, even the way I've said that, I feel like as a way is minimizing it. And, I think in a way I am minimizing that, because there are real things that are happening right now with these cuts that are against, this so-called common ground. And I wonder if, somebody like Kennedy, and you said there's some, rifts between MAHA and MAGA, but with all this like complexity that's required, and the way he's handled these cuts, he's even been caught off guard himself. He said, "Oh, look, I want to bring all of these things back," and he says he's going to bring things back, but we don't see them actually coming back. And so this is
for you, it's like it's a line in the sand that, like, if you were gonna live with the reality with all these cuts, it's hard to do a lot of the common things.
Yeah, like I don't
forward.
think we're at a like are there's too much actionable things right now to be really so like optimistic about some common ground things, to be quite frank. Megan, I don't know how you feel about that. As
I mean, I'm super. I said I'm quite worried for the health of America and for our ability to do good science going forwards. Both the folks that are actively doing, I mean, healthcare is already broken. And now, as was public health, and now they're both more broken. And I don't know how we recreate them in a hurry, and how we do it without seeing real, I mean, again, there is real harm today. That harm is going to multiply over time. The only way that I can see it, Mark, is that it is an invitation for us to shape something better, but we got to do so quickly, because I
mean, Elizabeth, do you trust that RFK can make these types of decisions that are gonna really help the health of everyone and not just those who were sort of in his MAHA movement? I mean, do you trust that he's able to bridge this type of divide that we're in?
I think that in my experience, just from the folks that I'm in communication with, the community is incredibly, incredibly critical of the cuts, particularly to the point where Nancy, who was one of the MAHA moms, was on the call, has organized this, amazing group of moms who are reliant on Medicaid to take care of their children. In her case, her community, she's got a lot of parents of adult children with disabilities that are not going to have care, particularly when their parents age to a point where they're not able to do it themselves. And so there is a lot of action that's happening within the MAHA grassroots to speak out against the parts that we don't agree with. Something that Mark Harris had mentioned on the call was that, if it was up to a lot of us, we would certainly be speaking out more so than what we've seen from Kennedy against these cuts and the way that a lot of these things were kind of done around him, and against the plan that he had kind of laid out for how he wanted to do this. So certainly, that makes it a lot more difficult for him to accomplish, his goals in terms of, reversing the chronic disease epidemic, cleaning up our food and our environment, the things that we interact with in our life. So, I would echo, yeah, it's concerning. We're concerned about some of these broad stroke decisions that have been made, not just at HHS, but a lot of the agencies across the federal government, if not all of the agencies across the federal government, are feeling the impacts of the DOJ cuts.
Yeah, it's almost like we need another Zoom, Brenda, where we have public health, we've got MAHA, we've got MAGA, and we got Russell Vaught of the OMB. Like, it's just an interesting conversation where you could start to see similarities between public health and MAHA. And then there's this other part of this that is, pushing through a complete reimagining of the amount of money that we want to devote to government and to government science and to public health. And that's that's kind of weighing on everybody right now too. And like Elizabeth, you're saying like that ain't MAHA, and Megan saying that's killing public health and science. And I just wonder if there's a point where maybe MAHA's not always going to be attached to MAGA, and maybe MAHA's frankly not always going to be attached to RFK because he's part of the cabinet now. So like maybe the story isn't over, and I think a lot of the decisions that are coming, I think could shake up this whole thing.
That would be an epic Zoom. I don't know if I can organize that, but I will. I love a good challenge. Listen, thank you for this being on a journey with us, listeners. This was an epic conversation. And look, the reason we wanted to really just kind of be in it was because we don't want to short shrift this. These relationships take time to build and they take time to develop, and the conversations take time to develop. And I think if there's one thing I would leave anyone with thinking is that don't be transactional. Don't try to convince people of something. I really feel strongly that without building trust, you really can't really achieve much. So I just want to thank our guests, Megan Ranney, Elizabeth Frost. I hope that you liked round 2 of this with us. And we're gonna be doing another conversation with these groups again. A huge thank you to the Ohio chapter of the MAHA movement, as well as from the public health side of things. And please do leave us any comment, questions at whyshoulditrustyou.net. If you like this podcast, or certainly if you have thoughts about it, send it there. And then leave us a like, review, all that good stuff. And we will see you right back here next week. Thank you.